Good morning to everybody. This is 10 o'clock Houston time, means Enjoy Science. And Enjoy Science, it's a webinar designed by us at MD Anderson for all the big family of MD Anderson, clinician scientists, patients, patient advocates, and everybody who loves MD Anderson. Enjoy Science is under the organization of Dr. Giulio Draeta, and I have to thanks very much to Ellison Garth, to Liz Kent, and to Valerie Jimenez for all the hard work that they put on this webinar for several months. And it's my pleasure to co-host it with my colleague and friend Alessandra Ferraioli. I have to thanks to all of you, hundreds each time, who are attending this webinar, because without the attendee, the webinar cannot take place. And of course, I will ask you to keep using the chat for questions. And I have the most to ask to our colleague and friend Guillermo Garcia Manero for the fact that he found time to be with us at Enjoy Science and to show us a wonderful project. I would say what his focus of the activity, myelodysplastic syndrome, is one of the most interesting disease to work on. Why? Because the mechanism is not known a lot, so the therapy can be developed very much. And Guillermo is the #1 in the world in the study of this disease. He created here in probably 12, 15 years, Guillermo come more or less the time when I come here, one of the best program in the world, if not the largest in the world. He is also the director of the Moonshot MDS AML. So otherwise, he's wonderfully focused on excellent clinics. He's all the time in clinics. This is why I thank him very much for being with us. And also he is quite all the extra time in the lab trying to find mechanisms, trying to find biomarkers, trying to find therapeutics for the patient. So Guillermo, thank you very much for being with us, and we are all looking for your very interesting presentation. Good luck.
Thank you, George, for this very kind presentation. You've been my friend for many years, and I really appreciate this. And I want to also thank Dr. Ferraioli for inviting me as well. Please let me know if you can hear me well, George. All good? Okay, so thank you again for this great opportunity. This is a great morning actually here in Houston. And when I was asked about this last week, I thought, well, you know, there are so many topics that we could cover, but then I saw that Dr. Simona Cola is going to be giving a seminar next week. So I thought that perhaps I could focus on the clinical aspects of what we're doing in MDS, and then you will have a different, more basic representation from Dr. Cola's effort here also at MD Anderson. So I think this is going to be a very interesting tandem. So I'm sorry, so let me go to the slide. So first of all, I want to start showing that this is a very important team effort. For sure, what I'm gonna talk to you in the next hour is not just the effort of one individual, and it shows actually the complexity of what we do. So on the slide, you see Dr. Simona Cola and Yue Wei, who lead basic translational projects. There are a number of clinicians that are focused also on MDS and CMML, like Dr. Montalban, Dr. Naki, Dr. Sasaki, and Kelly Chen. And then very talented junior laboratory people, including Iran Ganan, Vera Demad, that just joined us from the Cleveland Clinic. And then again, this is in a way a multidisciplinary effort. So Rashmi Kanagal and Dr. Carlos Hueso Ramos, our main pathologist, plus Caleb and his team doing informatics, although Caleb just moved out to another university. And as George mentioned, we are very fortunate that we have support from the MDS AML Moonshot that has really allowed us to do a lot of these projects that probably would not be possible otherwise. And then, of course, we're in the context of the Department of Leukemia, and a lot of the data that I'm going to show you comes from the great work of our amazing research nurses here at MD Anderson. Now, this disease, as George said, has been difficult, or it still is difficult for a long time. One of my first professors was a very famous hematologist called Dr. Alan Erslev when I was in Philadelphia. And he was one of the persons that isolated erythropoietin. And in my head, I remember vividly when he told me, don't worry about this disease. This is kind of like a pre-leukemia focus on AML. And then a few years later, when I moved to MD Anderson, Dr. Kantarjian, my chair and mentor, told me, okay, you have to focus on this disease. And I thought he didn't like me because I thought he wanted to kill my career, because around 15 years ago, there were basically no drugs, no cell lines, no mouse models, no understanding of the genetics, and very difficult situation. So here at MD Anderson and multiple other programs around the world have really, I think, done a major effort that is now transforming the care of our patients. And as I hope I will be able to translate during this hour, show you how we're really changing therapeutics in this disease. First, I want to start giving you kind of a chronology of maybe what are the landmarks in this disease. And, you know, some of these may be a little bit mundane, but they were really important at their time. So it all starts probably in the late 90s with this IPSS classification. This is when Dr. Erslev was telling me, don't worry about this. The reality is that this was the first kind of intellectual framework trying to put together this disease. And then if you look here, 2004, 2005, 2006, we and others were able to develop and approve 3 compounds for this disease. And we were really excited, maybe a little bit arrogant, and we thought we were going to approve a drug every year for the rest of our careers. Of course, this did not happen. But they were very important compounds. So the first one was azacitidine, a hypomethylating agent. The second was lenalidomide, a drug that alters or has activity in patients with 5q minus alteration. And then Dr. Kantaryan, myself, Dr. Giampiero led the program that got decitabine approved for patients with MDS and also eventually AML. These compounds, these hypomethylating agents, have been transformative, and our lab here and many other groups focus on this understanding of epigenetic and DNA methylation alterations in leukemia for many years. So this has been really important, as you will see in the talk, also still remains as the scaffold of what we do. Now, in 2006, we stopped developing or approving drugs, not that we didn't try, but we kept working on this. So there was a major international effort that led to this cytogenetic classification of the disease. This is very important because it really allows us to start thinking about this condition in different subsets. But what I think was really the major breakthrough was the incorporation of next generation technologies in the investigation and also in the diagnosis and treatment of these conditions. And this is something that I'm gonna spend a little bit of time. And now I think times are changing. So we just got a compound approved for patients with MDS. This is the first one, I guess, in 14 years, luspatercept, a drug that modulates TGF-beta and has quite significant activity in restoring hematopoiesis, and particularly anemia in patients with MDS. And there is another compound that is with the FDA, an oral form of decitabine known as STX727, that was also led by the MD Anderson group, that we hope will be also approved for our patients. And this, I think, is going to be a major breakthrough in terms of how we can deliver therapy for our patients. So this is now starting to change in a very positive way, and there is quite a bit of excitement in our community in terms of new therapeutics. Now, this is an algorithm or a schema that we use to decide kind of what type of therapy we give to our patients. Now, if you look at the paper, this was when Dr. Atala was one of my fellows here at MD Anderson. He's now one of the leaders at the Medical College of Wisconsin. So around 12 years ago or so, this is more or less what we had. This actually has not changed a lot until today. So it all starts with a diagnosis. I'm not going to go into this, but this disease is very complex even to diagnose. So there's a lot of issues in terms of discrepancy rates. At MD Anderson, actually, it's around 20%. And it's one of the major reasons people come to MD Anderson to be evaluated for this condition. Once you confirm the diagnosis, we divide patients into what we call lower risk or higher risk. I'm not going to go into that. We use IPSS, RPSSR, maybe molecular annotation. And then if those patients that are in a lower risk category, there are a number of therapies that are out there. We actually just finally published data in the Annals of Internal Medicine with a randomized trial of iron chelation that showed positive data. This could be for discussion later. Of course, the use of growth factors. These hypomethylating agents are actually very interesting because this is something that is done mainly in North America, at least in the United States, not so much in Europe. Our data actually is highly positive in this context. We mentioned already lenalidomide, immune modulation, and then basically the main issue is when do you transplant this group of patients with lower risk disease. High risk is a little bit different, more complex. Age is important. Why? Because we're still talking about induction chemotherapies. You know, in the old days, we used to consider MDS kind of as a form of AML, and we used to treat a lot of our patients with induction chemotherapy. This is something that we do not use that frequently right now, but is still important, particularly for group of patients that are younger. So the question is here, should we use a hypomethylating agent? Should we use chemotherapy? When do we do transplant, etc.? Now, we don't really have answers actually for a lot of these questions, but there is a theme evolving that is basically this concept of total therapy, where we try to basically sequence these therapies. But this is basically what we have today, kind of meager, you know, some supportive care interventions for lower risk, and then whether chemo or hypomethylating agent for higher risk disease, and of course, potentially role for stem cell transplantation. Okay. Now, as I said earlier, this probably changed around the time of this paper. This is a nice paper that was part of effort from the MDS P01 that we had with the Dana-Farber group. And this paper in the New England Journal at that time was the first kind of molecular taxonomy of this disease. Now, this is of course very rudimentary compared to what we have today in terms of genomics, so number of genes. But you start seeing here how these patients actually dichotomize. So we have the subset of patients with P53 mutation, then patients with TET2, and you see very quickly that it seems that there are two patterns of co-mutations, and we started to see that we could basically align these molecular alterations with a specific morphological and clinical characteristics of this disease, as you see here, 5q minus, complex cytogenetic, etc. So this was the first version of this. Now, this was led or taken over very quickly by major efforts in Europe and Japan. This is one of the most commonly used papers from the UK group. And basically what you see here is what would be now the accepted molecular distribution of genomic events in this disease. So most common frequently mutated gene in this condition is splicing gene known as SF3B1. And then you see this group of maybe 20, 30 genes that are commonly mutated in this condition that, as you will see later, could have both a prognostic and therapeutic value. Now, there is something very interesting in this slide, if you look at it, is that in purple, we still see the chromosomal alterations. And that to me was intriguing because we all thought that once we had this kind of genomic data, we were going to be replacing conventional genomic cytogenetic testing. And that's not the case. I think these assays actually give different representations of different biological processes that are important in terms of understanding this condition. And now we're working actually on Bayesian network type of modeling, trying to figure out what will be different subsets of subgroups of these patients based on specific cytogenetic and molecular alterations. But this is an important slide that is allowing us actually to conceptualize what's happening to patients with MDS. And this is an example of how we are putting this data together. So this is an effort here from our genomic data. And we did an analysis looking at the impact, for instance, of the number of mutations on survival. IPSSR is kind of the standard today risk classification of this disease. So of course, intermediate, very high, associated with different risks. But then, for instance, you can have specific mutations like TP53, well-known poor risk molecular feature. But interestingly, you have other facets, like for instance, number of mutations, as you see here, those patients with 3 or more mutations that have a significantly worse prognosis. Now, what is interesting actually is that this could be in the context of patients with quote-unquote lower risk disease, meaning a low percentage of blast, or let's say minimal cytogenetic alterations that could have actually a poor prognosis based on the molecular features that we see by this next generation context. So this has not been fully validated. Now we're expecting a major effort from an international group that is putting together IPSR with molecular, and I've seen some data from different countries where they basically coalesce all this data together. So I hope that at some point this year, if not early next year, we'll have a true comprehensive molecular clinical classification of this disease. Now, what I think is going to happen, and this is going to be, I hope, presented in a lot more detail by Dr. Kola. And indeed, actually, I removed a lot of the data that I had on an original version of this presentation, so Dr. Kola doesn't duplicate this work, is that this is going to be actually superseded by the single-cell RNA-seq and hopefully at some point a molecular type of assays. And as George was alluding in the introduction, that was very kind, by the way, is that this kind of data or analysis not only will help us understand what happens in MDS and AML, but also in normal hematopoiesis. So I'm going to start going into this concept of clonal hematopoiesis or CHIP. That is something that is really important for our program, that actually coalesces this concept of aging with normal hematopoiesis and then the emergence of these leukemias. So this is data again generated by Dr. Kola, where she and Irene Ganan has been looking at how hematopoiesis looks in patients that are either young, older, these are healthy normal individuals, or those patients with clonal hematopoiesis. And what we're starting to see actually is that these patterns at the RNA-seq looking at these single-cell type of assays are different. For instance, if you compare all hematopoietic stem cell versus a clonal hematopoietic stem cells, and basically you see that the evolution of these clones is totally different, suggesting that actually in those patients with this type of abnormalities, we can see alterations in specific clones. I am particularly excited about this technology because today I think this is research, but we're starting to use this kind of assays sequentially in clinical trials to see, for instance, if whatever therapy that we use, it's modifying this particular clone or how it is affecting these clones sequentially during the course of therapy. So this is really important for us. And again, this is another example, and I don't want to spend a lot of time because of the talk next week, where you see actually different hierarchies in terms of the different gene expression profiles these hematopoietic stem cells have. So I think that the point here actually is that we may be able to really come with true diagnostic and therapeutic type of options by looking at these single cell maps that allow us, for instance, as you can see here, to very clearly distinguish what would be normal from an MDS. And as you see there in the context of the MDS, there may be actually different subsets that Dr. Kola will be describing next week. Now, before we go into this, I'd like to diverse a little bit because this will go back to this concept of CHIP and clonal hematopoiesis. That is, what is the cause of death? So one of the first projects that I did when I started focusing on MDS was actually looking at what happens to our patients, what is the cause of death. Going back to Dr. Erslev, he taught me these patients go from MDS and they all die from AML, when I actually realized that was not the case from this publication. Indeed, actually, what we see is that the majority of our patients died from either an infection or a bleeding complication, suggesting that the cause of death is actually related to complications of MDS, and that if people like me want to improve the natural history of this disease, we have to really focus on MDS and not that much on transformation. That still is a very important issue of course, in the research in this particular area. So why is this important? So a number of years ago, Kiran Naqvi here published a paper that I never understood, but I was very proud of it. So basically what we did here was to put together a classification that allows you to compute comorbidities, meaning other diseases that these patients may have, and this is shown here. So for instance, you see, of course, the most frequent comorbidity, cardiovascular disease, because we work in a cancer center, malignancies, and so forth. Now, this is called ACE27. There are other classifications that we can use, but this is a cancer-specific one. And then you can see basically that the majority of our patients, because this is a disease of aging, have some degree of comorbidity that actually can be severe to moderate in more than a third of our patients. Now, what was very interesting from this is shown here, and I never understood this. That is, these comorbidities actually synergize with the outcomes of patients with MDS. So for instance, when we build a multivariable model, you see age, of course the IPSS, but also the score. And to me, this was fascinating because what it meant was that, of course, you have MDS and you have bad diabetes, your prognosis is not going to be better. It's going to be worse. But what we found here is that they were independent and somehow actually synergizing. I couldn't understand that. In my mind, although I had no proof of this, that probably implied that perhaps there was some type of commonality to what was causing, let's say, the MDS, and particularly, let's say, the comorbidity. So this concept was there. Of course, this paper was looked from a more clinical perspective, trying to figure out how we can really assess outcomes in patients with MDS based on their comorbidities. And what became really fascinating to me and has transformed this field has been this issue of understanding how at the molecular level these comorbidities actually may be related to clonal hematopoiesis. So this is a very fundamental paper now a couple of years ago by Jose Fuster at Yale in New Haven, looking at mouse systems of atherosclerosis crossed with mouse models of, clonal hematopoiesis, indicating actually that the cells that go and home in the atherosclerotic bed are actually of hematopoietic origin. When this data came out, together, of course, with the data from Ben Ebert at the Dana-Farber that had actually, before this paper, really shown this at the clinical level, this actually became really a landmark moment because we started to understand that perhaps this concept that we have, in a way, clinically shown in the original JCO paper indeed actually was happening, because this data suggests that there is a common cellular and molecular origin potentially for a subset of these patients. And this has tremendous clinical implications because, of course, now if the concept is that perhaps there is some macrophage that is mutated in MDS that perhaps has the ability now to home into this atherosclerotic bed, the question is, if I treat this patient systemically, like we do, for instance, with a hypomethylating agent, is it possible now that I may be changing the natural history of the disease, not only because I'm putting this patient in remission, but also because somehow I am altering this. Now, we have not tested this. There's no trial that I'm aware of where we're looking at this kind of biomarker, but I think this needs to be done for sure in the future. Now, last year, again, Kiran Naqvi published what I think is actually a very, very important paper where we ask a very simple question, that is, if it's true that at least in clonal hematopoiesis, particular mutation, let's say TET2 DNMT3A, is associated with, let's say, atherosclerosis, meaning heart disease, is it possible that this is actually expanded to other genes? And then are the relationships between mutations and comorbidity kind of stochastic, or can you predict what type of comorbidity the patient is going to develop based on particular mutations? So to answer this question, Kiran looked at a group of patients here at MD Anderson that had been molecularly annotated and basically correlated the presence of mutation with particular ACE27 comorbidity score. And this was very interesting because actually we observed that there is directionality, meaning that particular mutations are more frequently associated with particular type of comorbidities. Now, in our hands, actually, we saw a more direct correlation between DNMT3A mutation and heart disease. There are patients with a JAK2 MDS that have, of course, increased incidence of veno-occlusive disease. And then, for instance, TP53 not only was associated with secondary malignancies or therapy-related disease, but also with endocrine alterations and pulmonary disease. So this data for us is important because it may allow us to align particular comorbidities with their disease and this particular mutation. So this is something that now we're moving forward in some of our programs. And this is actually kind of relevant because going back a number of years ago, we designed a clinical trial for patients that do not qualify for conventional clinical trials because they had comorbidities. And in the past, we have shown that the ACE27 actually was a very important predictor of outcome. But when actually we treated this group of patients and we implemented therapy, very quickly, actually, we saw that we neglected the prognostic value of the ACE27 score, suggesting again that somehow these therapies were modulating the potential adverse events of these comorbidities. Of course, this needs to be tested in different concepts, but it opens this idea of treating patients with comorbidities and other conditions with therapies in this context, trying to also do some type of annotation based on a specific comorbidity and a specific molecular alteration that the patient may have. So I think this is really important work that we need to move forward. Now, clonal hematopoiesis is a big concept. MD Anderson is not a big general hospital where we have tools really or number of patients to correlate cardiac disease with CHIP or MDS. We have focused, and this has been led by Dr. Koichi Takahashi, in this concept of therapy-related clonal hematopoiesis. So a couple of years ago, we published this data, and this actually comes from a very important paper from the WashU group, showing that patients that had therapy-related MDS that had then developed P53 MDS AML, if you went back to the time before they developed the primary malignancy, I believe most of the patients were people with non-Hodgkin's lymphoma. If you look at them before they got any chemo or radiation therapy, you could actually, using a sensitive test, find the mutation before they were exposed to any therapy. This is very important, of course, because traditionally we have thought that was the chemo and the radiation therapy that caused the mutation on P53 that then caused the disease. This basically suggested that we could somehow predict who may be at risk of developing therapy-related disorder. So Koichi here did kind of like detective work, identified 15 patients from MD Anderson that had basically all the life history here at MD Anderson mapped at through different testing. And he tested at the molecular level sequentially these patients from the time of their original diagnosis before they had gotten any chemo radiation therapy, and then at different endpoints, as you see in this slide. And I think this is a major contribution because what he found was that, first of all, this therapy-related concept is not only related to P53, but other mutations. And indeed, actually, if you have any level or any type of molecular alteration, meaning CHIP, or any type of mutation by this type of genomic testing, these patients actually at a very high risk of developing therapy-related disease. And this is basically summarized here. So basically, the concept is that we could predict who is at risk of developing therapy-related disease by performing a genomic analysis before these patients are treated with chemo and radiation therapy. Now, we're thinking about how to approach this issue because, of course, doing this globally is probably beyond our capacity. But we had discussed or discovered in a prior publication the subset of patients that are at higher risk for this condition. And at MD Anderson, these seem to be individuals that have lymphoid malignancies, maybe because some of these patients are treated with an autologous stem cell transplantation. That is something that we saw very commonly associated with type of therapy-related conditions. So as you will see, though, at the end of the talk, this is now having also a major impact from precision medicine type of concept by being able to target P53. So basically, this is a theme that we are trying to put together again through the Moonshot program and trying to see how can we develop some type of preventive type of approach at this for this group of patients with very high risk of disease in terms of secondary malignancies, particularly in this context of lymphoma, myeloma, going through an autologous stem cell transplantation. Now, we have not launched this. We're thinking about some type of clinical trial, but we have now hesitated, and this is my fault, for a little bit of time in terms of what will be the proper therapeutics and what will be the readout. Because as you know, these patients with clonal hematopoiesis may take many, many years to develop a disease. So it's difficult actually to see what would be the proper readout for an intervention here. But I think this is going to be a major thing linking aging with the emergence of myelodysplastic syndrome, and perhaps this group of patients with therapy-related disease could be a subset of patients that will really benefit from this type of intervention. Moving beyond into what is true MDS, just a quick slide showing actually the 5 group of patients, or 6 that we're focusing. So of course, on the left, those patients with ICOS CHIP, I already spent a little bit of time on this. And then we said that we divide them into low risk, high risk. And then the main concept here is that the natural history of this disease really changes when these patients are treated with hypomethylating agent, azacitidine, decitabine, particularly at the time of failure. So a lot of our efforts are trying to figure out how we change the natural history of this disease, because the prognosis of those patients with an HMA failure as you see here at the bottom of the slide, is from like 4 months to like a year and a half. So basically a very poor prognosis situation. So let's start a little bit with low-risk MDS. And here is actually where we have a major difference with our European colleagues. We're really thinking about how to treat this disease earlier, perhaps treating patients with transfusion-independent disease. That is something that is not done probably outside some centers in the United States. So a number of years ago, I developed a very simple scoring system that is shown here. This is the low-risk MD Anderson model. This is before we had genomic testing. And this is the so-called low-risk disease. And as you see here, yes, there are people with a few points that have an excellent survival without therapy. But then you have this group of patients here. We have 5, 6, 7 points on the score that basically have a survival that is maybe a year, a little bit more. And they're actually in this group of patients with lower risk disease. So for sure, there is a subset of patients with lower risk MDS that can be treated with therapy, and this is really important. And we're actually testing this in the context of a randomized prospective clinical trial that we hope to present this year pretty soon. Now, in parallel, we started working with these oral hypomethylating agents, and this is data from the original phase 1, phase 0 of oral azacitidine. And here, actually, what we show is that by providing very low doses of this compound, we actually had very significant response rate of around 40 to 45%. So in my head, this meant that perhaps we could come with low-intensity type of approaches that could be non-toxic that perhaps we could then use in patients with lower risk disease. So this has been one of the goals for us over the last few years. This is actually the PK profile of oral azacitidine. This drug now is called CC486, and we think that this compound actually may be approved actually for AML in the next few months. I'm not sure about this, but this will be a major breakthrough also for our patients. But this is the PK curve of oral AZA, and what you see here actually is very low exposure, yet very significant clinical activity, as you saw in the prior slide. Now, because we were anxious, we then moved this concept into what we call attenuated dosing with conventional azacitidine or decitabine. And again, this was a very nice study, kind of trying to compare low-dose decitabine to low-dose azacitidine. But if you pay attention here, we're showing actually almost 30 to 40% complete remission rate with these very non-toxic type of approaches in patients with lower risk MDS. So this is very important data. Again, this is not commonly used in Europe, frequently used in this country. Actually, it's part of the NCCN guidelines. And this has led to the study that has not read yet, that is a randomized study looking at both transfusion-dependent and independent patients, different forms of therapy, that when it comes out, I think it's going to give us quite a bit of information in terms of what are the modalities and whether these strategies have any value or not in patients with lower risk myelodysplastic syndrome. So maybe, George, you could invite me next year to show some of this data, because I think it's going to be quite important. Another breakthrough along these lines is actually the development of another oral hypomethylating agent, that is this compound STX727, or oral decitabine. This was presented at ASH this year. This is actually a very interesting compound. What we do is give the conventional decitabine IV, we give IV orally, together with a drug called cedusuradine, that is a oral cytidine deaminase inhibitor. And basically, by inhibiting the catabolic activity that degrades the cytidine, now you render this compound fully, basically I don't know how to say that now. Basically, with similar pharmacokinetic profile to IV decitabine, except that you're doing this through the oral route. So we perform a phase 1/2 purely pharmacodynamic profile. This is actually very interesting to do. And as you can see here, this will take a little bit of time to see, we were able to find the actual ratio of the cytidine to the cytidine deaminase inhibitor that basically was equivalent to IV decitabine. And basically then we tested this in a phase 3 trial. Now, this study actually, even if it's called a phase 3, it was a very interestingly designed trial where actually was a single arm study where patients were randomized to 2 different sequences of this compound. And what we wanted to do here was to compare the pharmacokinetic profile of IV versus oral decitabine in the same patient, and we just altered whether they were doing this on month 2 or month 1. And basically what we found was that the PK profile that is shown here in this box, the ratio, was virtually identical. This data was just published in Blood a few weeks ago, indicating that this oral compound could replace IV decitabine. I think this is going to be important. Another topic going back here, and this is actually quite relevant, is that if we are able to alter the ratio of the decitabine versus decitabine deaminase inhibitor, we actually may be able to come with different forms of this drug that could then be used in AML or maybe lower risk MDS with excellent kind of targeted pharmacokinetic profiling. So we're really following that lead as well. And then, of course, for many years, and this is an assay developed by Jean-Pierre Issa when he was here, this is called the line 1, that is basically a biomarker of DNA hypomethylation. We found that the effect on DNA methylation was, identical between the IV and the oral compound. So basically what we are seeing here is that these kind of compounds, again, these have similar clinical activity what we had to IV decitabine. So what we see completing this part of the oral, the low-risk disease, is that it is possible that perhaps these attenuated forms of hypomethylating agents, maybe through oral routes, could be at some point a standard of care for our patients. Moving to higher risk MDS, this is a little bit more complex in terms of approval of compounds, but I think we're going to get there pretty soon. And why is this complex is that a number of years ago, Pierre Fenot, an international group in France, performed a very important randomized trial with azacitidine showing improvement in survival in patients with high-risk MDS. And this is data that anybody that works in MDS is aware of, showing basically significant improvement in survival in this group of patients. And this is our standard, but this has been very difficult to beat from the context of clinical trials, because now you have to basically beat this 24-month median survival. Now, this is a good thing for the patients, but of course makes the design of these clinical trials a little bit complex. Now, the question is this data 100% representative of what happens? So there is now quite a bit of data indicating that perhaps the median survival of these patients is lower, maybe around 17 months, not 24 months. And the incorporation of this genomic data now is starting to allow us to identify different subset of patients. So this is just an example and an anecdote, but I think this is very important. So a couple of years ago, we found that a very small subset of patients, maybe 1 to 2% of our patients, have a mutation on MPN1. As you know, this is a gene that is frequently mutated in AML, a very good prognostic feature if you treat the patients with high-dose chemo. So we wanted to see what happened to our patients with MDS, with MPN1 mutation, treated with this type of approach. And what we found basically is that the cure rate is almost 100% if you give these patients some type of high-dose chemo with a stem cell transplant. This is transformative because today we cannot cure this group of patients. So now this is only 1%, but we see 500 patients a year with this disease. You know, it means that maybe 5 or so of these patients could really have a very significant change on their outlook if they go through this genomic annotation. And these are actually true MDS, not AML group of patients. What about developing second-generation hypomethylating agents? A drug like that is wadecitabine or SGI-110. This is data presented at ASH a couple of times. I think last time was last year. And this is a very active compound being tested in AML and MDS. But the reason why I put this slide is here, not only because of the response rate, but going back to this issue of the survival. If you look at it, okay, 17 months. I just showed you a slide with 24 months. So I said, why is he even talking about this? Well, because when we actually look at these patients at the molecular level, and we separated them by TP53 status, you now see in blue these patients with wild-type disease that have a survival that is over 30 months. This is really significant data. And it goes a little bit against this dogma that the standard of care for these patients with P53 is some form of a hypomethylating agent. What we're showing actually is that indeed actually patients without a P53 mutation, they do extremely well with this type of compounds. Now, this green data may be the best data that we have for P53 mutated MDS. That's a different story, but there is no argument, there is no argument that this survival is significantly better. So again, this is very important when trying to define or design what type of therapy we want to use for our patients in this type of mutational context. Now, we have been trying to incorporate different doublets to this hypomethylating agent. So this is another angle. Data from our group, this is a highly actually cited and simple paper, showed actually that patients with MDS tend to overexpress this PD-1 CTLA-4 axis. And what was very interesting is that this in cell systems was actually primed and triggered by exposure to the hypomethylating agent. So this is data from Hui Yang in our group. This is looking at the expression of the PD-1, CTLA-4, etc. And then this is in actual patients with sequential therapy. And this actually has allowed us to lead and design a number of clinical trials incorporating immune checkpoint inhibitors to patients with MDS. This is data presented at ASH a couple of years ago, looking at PD-1 inhibitors, CTLA-4 inhibitors. We see very high response rate, but that's actually not the interesting part. The interesting part actually is here. We're starting to see actually durability of those responses, particularly in patients with high-risk disease when treated with a CTLA-4 inhibitor, in this case, ipilimumab. So this is another lead that we're trying to follow in prospective clinical trials here, focusing on different scales of ipilimumab in combination with this particular compound. And this is now important because there are new generation immune checkpoint inhibitors. Of course, TIM3 is one of them, but there is significant interest now on blocking macrophage function or actually inhibiting inhibitory signaling macrophages. I guess that's the correct way to say that. This is a slide that Dr. Montalban Bravo gave me actually 5-6 years ago. I don't know why he was thinking about this, but this is really very important because, as you know now, there are a number of monoclonal antibodies targeting this CD47 that are showing quite a significant clinical activity in this context. This is data from the Moffitt and MD Anderson group presented at ASH this year, also led by Dr. Daber here, showing actually very high response rate in patients with MDS, a little bit less, but quite significant in patients with AML. And some of this data blocking the CD47 pertains to patients with P53 mutated disease that actually, as you know, have very poor prognosis. And I will follow on that lead a little bit later. The other aspect that is happening here in MDS, and this comes a lot from the work of Dr. Konopleva and Dr. Andrieff that led for many years BCL2 inhibition type of approaches in myeloid malignancies. This again, multi-center trial presented at ASH this year is basically the incorporation of venetoclax, a BCL2 inhibitor, to azacitidine. This data indicates a very high rate of response. And basically what we are gonna see now is a randomized phase 3 trial led actually by MD Anderson comparing AZA without venetoclax for patients with high-risk MDS. This data, although the follow-up was short, was very appealing without a median survival. So all of a sudden now we're starting to see doublets and perhaps second-generation hypomethylating agents with quite a bit of activity in patients with high-risk disease. But I'm going to finish the talk in the next few minutes looking at what is really important for us, is this HMA failure. And this is something that the MDS, MDL, AML moonshot has focused a lot. And this is an area of importance because the survival, as I showed earlier, is very poor. You have to start by understanding that there are two types of failure, what we call quote-unquote low risk, although the survival is 1.5 years, and then high risk, as I showed you earlier, 4 to 6 months. And this has been a very important area of investigation for us. Today, there is actually no standard of care for patients with lower risk disease. If we can transplant them, these patients do better, but unfortunately, a minority of these patients, because of their age and comorbidities, etc., are candidates for transplantation. So I'm going to start showing work by Yue Wei here at MD Anderson, who has studied it for now a decade. It all started actually with a ChIP-seq analysis looking at a modification known as H3K4 trimethylation that she used as a bait for this sequencing type of assays. And this slide actually summarizes almost 10 years of work looking at basically how this particular histone modification regulates different genes that are involved in innate immunity. And what we found actually is that these pathways actually are involved in resistance to these hypomethylating agents. And it seemed to be controlled by a Jumanji D3 or a histone demethylase known as KDM6B. We used to call this Jumanji D3. So the concept here is that there's some type of insult through cytokines, for instance, toll-like receptors, that then mediate activation of NF-kappa B, signaling through KDM6B, and then output basically out again of the receptors and the cytokines such as IL-6, IL-8, IL-1. And why we think this is important is that, as you will see in a slide in a couple of minutes, all of these are potential therapeutic targets. So with this information, UA developed a mouse model where she basically engineered these animals to overexpress KDM6B in the hematopoietic compartment. These animals develop a very slight phenotype. If you age them, actually, they develop kind of like low-risk MDS, and in time, actually, they'll have shorter survival. Now, you can accelerate this actually by giving inflammatory type of exposure, let's say LPS, things like that, that could activate this pathway. And again, if you look at RNA-seq type of experiments, you see this inflammatory type of responses as the number one type of reaction in this kind of system. Now, what is interesting is when she compares this to the human counterpart, actually the RNA-seq pathways are fundamental. Now, let me go back for a second to the prior slide. The concept in this cartoon, though, was that we know that only a minority of patients with MDS don't have mutations, so majority of them have some type of mutation. So the question is, what is first, this inflammatory type of cascade, excuse me, through Jumanji or some of these innate immune activations, or is the mutation? So we don't have an answer to that, but you then engineer a mouse model that has both, in this case, a TET2 mutation with overexpression of KDM6B. And this data was presented at ASH last year. We hope to publish this year. And then she compute actually the RNA-seq experiment from this mouse with data that we have from primary specimens from humans with this disease, with this TET2 mutation. And basically we see a very strong concordance in terms of the type of pathways that are altered in this group of patients, not only in the front line, but also in the context of HMA failure. And for instance, one of the notes that you see as very important is signaling through interleukin-1. Now, these animals may develop a more CMML MPN type of phenotype. This is known for TET2. This is, for instance, the spleen, and these are some of the characteristics. So we're now starting to deploy these kind of animals actually as systems in the clinic, meaning mouse clinics, to test some of the therapeutics that we're developing here at MD Anderson. And what we see is this kind of really important pro-inflammatory activation type of pathway. And we see actually something as well similar in patients with clonal hematopoiesis. So this is a very important library of molecular alterations that we're starting to deploy to basically inform our next generation clinical trials in this disease. And this is a cartoon that Dr. Montalban put together, basically showing how multiple of these alterations at the molecular level that we have shown in these kind of models actually have potential for therapeutic goals. So inhibitors of IRAK4, this is in collaboration with Dan Starsanowski in Cincinnati, inhibitors of RIP, other drugs that may interfere with mitochondrial function. And we are particularly interested on drugs that modulate interleukin-1 and also STING agonists. And this is through inflammasome and necrotoxic type of modulation. So all the studies are here at MD Anderson and will be moving forward, particularly in the context of HMA failure disease. Remember that I started the talk by showing this interleukin-1. And this is data that Dr. Kola shared with me from her work. And basically what she's showing here is that you see that if you look back at some of these top regulated genes, some of the ones that you see particularly in CHIP actually are actually here, are overexpressing interleukin-1. Now, I am fascinated by this because hopefully in the next few weeks, we'll be launching a study using a monoclonal antibody against the interleukin-1. And our goal actually is to sequentially follow what happens to these early hematopoietic stem cell clones that are actually characterized by expression of interleukin-1. This could actually be a very fundamental clinical trial for sure if it has clinical activity. Now, briefly, high-risk disease. This has been our problem for many years. This is from a seminal phase 3 study that was a negative study, but allowed to define this disease. We showed two types of HMA high-risk failure, what we call primary here in red and secondary in blue. This drug, rigosertib, is now completing a clinical trial in this specific subset of patients with primary HMA failure. We should see this data actually this year. But this is an area that Dr. Kola and her group has really worked over the last few years. He has a major publication, we hope, actually in Nature, and I'm sure that he will be presenting some of this data next week. I'm not going to go into a lot of detail, but what he has shown here is that if you look at the hematopoiesis of these patients with HMA failure in the high-risk context, you start seeing subset of patients with different RNA-seq pathways, and we're starting to use this in therapeutic clinical trial context. So for instance, we now have a number of trials using anti-BCL2 therapies in this group of patients that overexpress these pathways that make us believe that they will be extremely sensitive. Now, why is this very important is because if you look here in the bottom, some of these patients are actually, half of them may have pathways that actually will tell you that perhaps there will be patients that they may not benefit at all from this type of BCL2 intervention. So we're going to be testing this pretty soon in prospective clinical trials. And to finish, very quickly, moving a little bit into targeted type of options. So here at MD Anderson, Dr. DiNardo, Dr. Konopleva helped develop IDH2 inhibitors, IDH1. These are also mutated in MDS, although at a lesser extent than in AML. There is a subset of patients that have FLT3 mutated disease, and then finally TP53. I'm not going to go through this in a lot of detail. Of course, P53, very important gene. This is data published recently by Guillermo Montalban, looking at different constellations of different codon mutations of P53 and cytogenetic alterations. But why I'm making this is because there is a new compound that just completed a phase 3 trial led by us and the Moffitt group, randomizing high-risk MDS patients with P53 mutations. And basically, the data that we have shown in the first phase 1, phase 2 data was very high response rate and durability of responses. And if you look actually at data from France and also from the Moffitt group, a very high rate of being able to take these patients to transplantation and survivals that are longer than expected. So it may be that pretty soon we may have not only therapies directed to these other mutations that I mentioned earlier, but also for P53. And the results of this trial should come out pretty soon. Now with that, and for time, I'm just going to give one last slide, and this again from Dr. Kola, that basically says that although we are very excited in terms of what we have developed and our understanding of the molecular level of this disease, if you put this map of hematopoiesis, this is from John Dix, and then you apply this to what Simona has studied in MDS, what we found is, or what she has found, is that the hematopoietic stem cell in this disease is really altered at a very high frequency in a majority of the patients. And this is very different than in AML, where the disease is more a disease of progenitors. What is the corollary? That unfortunately, the cure rate is not going to be that significant or that easy to achieve, because this means that somehow we will have to really perturb and modify these stem cells. So we have to be also a little bit humble in terms of how we see the future for our patients, because the problem still is in that particular context. And with that, I really want to finish. I want to have some time for questions. These are some of the conclusions from therapeutic perspective, a number of drugs that are going to be approved, a lot of phase 3 trials that are reading. So we're going to go from that 2008 slide to basically, hopefully, a number of doublets and new agents. Oral therapies are going to be very important, but we have a long work and time to go. I think there are multiple areas. As George was saying, this is a very important area of investigation because it also, has these connotations with aging, with normal hematopoiesis. And again, I want to really thank you for this opportunity, for the 240 people at some point that listen to this. And I hope that we have some time for some questions. George, thank you very much.
Guillermo, thank you very much. It was a wonderful talk, and in fact, it was from all the alphabet of myelodysplastic syndrome. So I'm sure you will be the first one who will cure MDS in this world. So now, in order to start with a question, it popped up a question in my head when you was talking about checkpoint inhibitors. Now, did you ever test it in the patient's mutation load of exome mutations in these patients? Did really the one who respond to checkpoint inhibitors correlate with high number of mutation load and so on?
No, yes. So we tested that. As you know, we check our patients by 81 gene panel mutation profile that we can assess for BAF as well. And interestingly, we did not see that in our patients. Now, it is possible that these cohorts were all exploratory at the beginning. So it's not that we have hundreds of patients treated here. We are now expanding the ipilimumab arm here. And this is one of the questions that we're asking. Is there a correlation with particular mutations? And those patients that have more mutations, perhaps more genomic instability, is it possible that they respond to therapy? Interestingly, George, we're seeing responses in those patients with P53 mutated disease that actually can achieve with this type of immune therapy complete molecular and cytogenetic responses.
Thank you. Other questions? So I still have a question, Guillermo. Where did you see, because this is a very complex and a very heterogeneous disease, where did you see the future of the molecular mechanism discoveries and the therapeutics, let's say in 5 years or 5 years from now? You know, what do you think?
I think actually this is probably not just going to be for MDS. I think it's going to be for all malignancies, but MDS is a nice model for this. I think that once we go from, you know, today, the pathologist will give you a morphological readout of this disease. I'll show you some data with the single cell analysis that really can tell you if hematopoiesis is perturbed or not. We are working on double assays, looking at single cell assays with mutation and gene expression profile. I think that once we deploy this kind of assays in a more clinical translational venue, we're going to be able really to understand at the individual level, not single cell, but at the patient level, what are actually the pathways. Because actually it's interesting that we have a lot of compounds that can perturb these pathways. So if we could develop maps for these patients and say, okay, this patient has P53 mutation with this co-mutation and this gene signaling, I think that's when we are going to be able to really attack this disease, restore hematopoiesis, and somehow decrease rate of transformation to AML. So I think that this kind of data I'm particularly excited about, and we can deploy clinically. This is going to really enhance our ability to do true informed clinical targeted trials. I think this is where this is going to go. We are actually starting to incorporate, thanks to the support of Simona Cola, the Moonshot, and Nick Nevin here, who has given us advice, and others, you know, how to actually implement this type of single cell technology in clinical trials. I think that's going to be transformative.
Yes, thank you. Another question. Do you see then genetic analysis as being part of the treatment of patient? How often should this genetic analysis be repeated through patient history?
This is really fundamental question. Now, sometimes because we work in this really incredible place where you know, everything is possible, we don't realize that there is a world outside here. So if I give a talk in sometimes other continents or poor countries, actually now with these virtual talks, you've been talking with people in really poor countries, and you say, well, we need genomic testing, and then they say, well, doctor, we don't have this kind of tests in whatever country. So of course I understand that this may not be applicable today worldwide, but today I don't see how at a certain level you will practice this kind of medicine without some type of genetic test. So this is mandatory. As I think I showed during the talk, this gives you prognostic data, it gives you therapeutic data, and that's how we approach our patients in the clinic. But the second part of the question is very important. That is, do these genomic alterations fluctuate in time? And they do. So these are actually highly dynamic processes. And we have shown this for individual genes over the last few years. So for instance, I said that FLT3 mutation is happening in MDS, and people said he's crazy because this is not true. Well, at baseline, yes, this is not true. But at the time of HMA failure, around 20% of the patients acquire a FLT3 mutation. So we see these very dynamic changes in these mutations. And these are actually part of the patterns of resistance to drugs. So this is very important. So you probably need to assess clinically these genomic patterns sequentially during therapy, particularly when you're going to change therapy, and particularly at the time of failure, because very frequently you will see now detectability of mutations on IDH1, IDH2, FLT3, etc. This is very fundamental. And that's actually how perhaps outcomes of our patients here is a little bit better than expected, just because we are able to annotate these patients at the molecular level. So this is a very important question clinically.
Thank you very much. So with this, Guillermo, thank you. It was a wonderful talk. It shows, in fact, why MD Anderson is number one, because it has people like you who can do from wonderful clinic to wonderful science, and everything is for our patients. And with this, please, all of you, the hundreds who attend, next Friday, 10 a.m., it's Simona Cola, wonderful science. And of course, keep in mind, the bad days are passing, good days are coming, and keep in mind, science, it's a hobby, but also science unify people. Science unify people independent of race and place. And as Guillermo showed you, science is something that is done in large collective of people, large groups, who is putting together a lot of knowledge. Guillermo, if you want to say something?
Yes, I want to say something very quickly. First, go to the talk of Dr. Cola, because he's going to explain what I just talked in a much better detail. But number two, George, you are wrong. MD Anderson is not number one thanks to me. It's actually number one thanks to people like you and Simona, because we get your discoveries in the lab into the clinic. So we will not be here if it was not for the research that you can do. And we are grateful for that, George.
Thank you very much. Thank you, all of you. Thank you, Guillermo. Thank you, people who attend. And let's meet next week, all of us. Thank you, and enjoy science and enjoy discoveries.
Thank you.